Okay, we'll go ahead and get started. My name is Ken Nepple. I'm a urologist at the University of Iowa. I did a fellowship at Washington University in St. Louis in urologic oncology. So very happy to be involved with the program. I have our excellent resident moderator, Dr. Justin Drobish. Drobish is sporting the COVID mustache for our amusement later, potentially. So appreciate him being available. So topic for today is going to be relatively dense as far as information and kind of breadth. We're looking at non-metastatic high-risk prostate cancer and also looking at the related topic of biochemical recurrence. So I have no specific financial disclosures or commercial disclosures. In the interest of social distancing, this is some street signs that our hospital had put together as far as standing together. My children, all three of them, got to be brainstorming and realized the backside was available. That is a lawn tortoise that had replaced Wilbur, our cat, who had died a while back. So they put the turtle there and said, why'd the turtle not cross the road? To keep social distance. So one other tidbit, as I live a little bit outside of town, a little bit rural here, and was talking with one of my neighbors, and they actually purchased a dairy cow because of some concerns related to COVID and milk. And so I now am aware that you need to milk a cow twice a day, and one dairy cow provides 4 gallons of milk a day. So if you get bored at dinner tonight, you can let your significant other or friend know about that. So in preparation for this, which is clearly a great program, I'm very happy to be involved. But I did go ahead and listen to the lectures from Dr. Cooperberg about prostate cancer screening, diagnosis, and risk stratification, and also another excellent lecture from Dr. Ben Ristow at Connecticut. And so I'm going to allude specifically to a few of the slides that they discussed. So if you've heard those lectures before, hopefully this will build on that. If you've not yet heard those, it should still be complimentary, and you can go back and review those with hopefully a little bit more knowledge in this space. So learning objectives. So we're going to try to talk about the evidence for treatment of high-risk prostate cancer and also where evidence may be lacking in some circumstances. Discuss evaluation management of biochemical recurrence after prostate cancer, not just high risk, but any prostate cancer. At the end, we're going to kind of run through relatively quickly some nuclear imaging that's available for prostate cancer and what may be on the horizon. And so specifically, I have an area not only in interest, not just in cancer treatment, but also in use the electronic health record, have a role here with our university hospital in doing that. So I'm also going to try to maybe highlight how you can use the medical record to provide some additional information for patient counseling and shared decision making. I also would like to acknowledge that this is a space where there is substantial practice variability. And we'll talk about some of that data. But I'm going to basically talk about the data I'm aware of, how I deal with patients that I'm seeing on a regular basis, what the evidence base for that is, but acknowledge that there may be some different management options. And there's some gray area as to what exactly standard of care is in some of these situations. But I think the more you can inform yourself in those situations where there is gray area, the better we're all gonna be, and your patients will be better also. So hopefully everyone on the call is aware of Indiana Jones. If not, then you can have something to do this weekend. But basically what we're searching for. So Indiana was always searching for things in the movies, but really, who should we be treating? Who should we not be treating? How should we treat them? What's the optimal treatment? And as we talk about multimodal therapy and sequencing therapy, what's the optimal sequence of that therapy? And also, what's the optimal patient counseling and shared decision-making that comes with that? And then I also inserted what I thought was a cool picture of a median lobe prostate along with the anatomic specimen there. So I'm going to give a 3-slide overview of kind of my impression of high-risk prostate cancer. And some of this is informed by experience, but also I give our medical student a lecture on principles of cancer surgery. And so this is a slide that I show them, and I think sometimes I allude to when I'm counseling patients. And so this, I'll walk you through it, lots of information, But basically, we're looking at 5-year survival rates for different types of cancer, specifically in 3 situations: localized disease, regional, what would be lymph node involvement, and distant disease. And so what we highlight there is for prostate cancer, 5-year survival, localized disease, basically 100%. Regional disease, so even if there's lymph node involvement, still basically 100%. It isn't until you have distant disease that you see an impact on 5-year survival. And sometimes I'll talk to patients who are extremely worried about their cancer and let them know that I see cancer as a spectrum. And you can contrast that to pancreatic cancer. If you're thought to have pancreatic cancer, your 5-year survival rate is still only 30%. So we want to keep in mind that cancer is important. We want to support patients' sort of thoughts, but maybe sometimes try to alleviate some of the anxiety that comes with using that cancer word. So in looking at a couple of those prior lectures that were done, one of the specific questions that had come up from a listener afterwards was, what do you tell patients about the natural history of prostate cancer? So I'll specifically say, what do you tell a patient who says, I know I have high-risk prostate cancer. It doesn't look like there's anything elsewhere in my body, but what if I don't do anything? So one of the best, looks at this that you're going to be able to find is from Peter Albertson. They had looked at patients who were managed conservatively in the state of Connecticut over a long period of time, 1971 to 1984. So they're able to look at how patients did that did not receive any active treatment and were just managed with either observation or androgen deprivation therapy. So if you look specifically at that outcomes in their conclusions, it was men with high-grade prostate cancer have a high probability of dying from prostate cancer within 10 years of diagnosis. Specifically, this is a great visual to show that. So if you look at the top columns, we have different age groups, but if we specifically highlight Gleason score 8 to 10 patients. So if you look at patients in their 50s, there's a huge proportion of patients that are going to die from prostate cancer if they're treated. But I think it's also notable that for patients in their early 70s, that their risk of dying of prostate cancer is almost equal to their risk of dying of any other cause. So even in older patients, there are still some specific risks that would come with not treating prostate cancer. And we'll talk about how that is kind of entrenched in some of the guidelines that we'll review. So how do we define high-risk prostate cancer? Dr. Cooperberg specifically, kind of highlighted some of the limitations about AUA versus NCCN, definitions. And so, I think there's a little bit of a Larry Flint kind of definition that high-risk prostate cancer is, it when you see it. But, this is a specific grouping, but I think it's easy to remember that you can consider, Gleason 8, 9, and 10, or, termed grade group 4 or 5. Patients as being in that high-risk group. Specifically, doesn't matter if we're calling patients, high risk or very high risk. It may not really matter when you look at guidelines because those groups are combined. But I think from a prediction and statistical research side, those groups are quite different if patients have high risk versus very high risk. And so as Dr. Cooperberg had talked about, I think CAPRA risk score is another great way to look at stratifying patients, by risk. And so another kind of question that would come up is, we see what we see in regular practice, but what about if you look at population-based data? How is high-risk prostate cancer treated in the real world? Another one of Dr. Cooperberg's slides that showed these changes over time. I know my computer monitor had kind of messed with the colors a little bit. And so I went ahead and went back to his original paper and included the chart there. And so what you can see is that the triangles, which are open triangles, which are the radical prostatectomy, there was a substantial increase in the number of patients who got radical prostatectomy from the early 2000s to the kind of 2010, 2013 neighborhood. During that same time, there was almost this identical decrease in the amount of primary androgen deprivation therapy. Radiation had some slow increases over time. But I see this on a relatively regular basis. Generationally, if I'm seeing a patient as a second opinion from a local urologist who may be a little bit older, they sometimes are told specifically, well, you have high-risk prostate cancer, you should not have surgery. And they're pointed towards either ADT or radiation therapy. But, I think as we'll discuss in a bit, there's more and more consideration about whether these patients may benefit from multimodal therapy, prostatectomy, potentially followed by radiation therapy if needed. But I think it's good to know kind of what the population-based trends are doing. And then I think the other really important distinction is, what we call patients as far as metastatic versus non-metastatic, because there clearly are differences in prognosis. And there's also, some unknown, what is the real truth about if a patient has microscopic metastatic disease or not. So one of my favorite slides, Dr. Kupperberg had alluded to this also. So Paul Lang, when he was at the University of Washington chairman for a long time, talked about prostate cancer in the context of 3 different animals. So there's the turtle that's really slow, it doesn't move, it's probably not going to go anywhere. Those are the active surveillance patients that we're okay just watching, or the older patients that we're okay not doing anything. There's the rabbit, which is at increased risk of getting out of the cage there, jumping to lymph nodes, and then potentially jumping elsewhere. But there's also this bird or this eagle that has moved so quickly that it's getting to other areas of the body. So you can see Dr. Kupperberg's slide there. What we're really talking about with high-risk prostate cancer is, can we distinguish those rabbits that are quickly moving but potentially controllable versus the birds who have, lack of a better term, already flown the coop. And so I got into a little Google search last night. I will apologize for this video or these pictures, but I said, can you really distinguish between a bird and a rabbit? And so there are a couple of internet photos of rabbit birds or a Twitter explosion over, is this a bird or a rabbit? So if you get bored during your isolation, you can look at that. But these patients have overlap. So if we talk initially about how do you distinguish who is a metastatic versus a non-metastatic patient. So this is one paper that looked at guidelines as far as what imaging to do. For local staging, we all know that MRI is going to be more valuable than CT scan. For distant regional staging, as far as lymph nodes, CT or MRI are both options. I know in my personal practice, which I kind of put there in purple, I tend to get an MRI, but we have it protocoled so that it's going higher up into the abdomen to also look at abdominal, lymph nodes. So that's the prostate lymph node, local distant staging. But then you also want to keep in mind with high-risk patients getting a bone scan. And I know in practice, a lot of the bone scans out in the community are just the nuclear medicine type. I know we have the ability here, if there's something that is in between, then the patient gets moved right down and they get a SPECT CT scan at the same time. And patients, I saw one this week, they said, I had a bone scan, then they came back and did another scan. What was that all about? And that was the SPECT CT part, so they can say, oh, this is definitively, degenerative disease versus looks more suspicious. In most of our practices, the use of nuclear imaging PET scans is going to be relatively uncommon. And we'll talk a little bit about that here in the slides coming up. If you're looking for a specific reference, this is a paper from Crawford and the group that looked at the specific question of what imaging should you do in these types of patients, but we won't go into that in great depth. I did think it's helpful to kind of highlight this ambiguity with a specific patient example. So this patient, we'll call him Mr. F. He was a 78-year-old gentleman, but very healthy. He had a PSA of 13.4. We had a standard biopsy, which was Gleason 6. However, we have discordant information here. Is this a low-risk patient, with a bigger prostate, or is this an intermediate risk patient? So based on that ambiguity, I obtained an MRI. That MRI showed a PIRETS 5, relatively classic anterior prostate, lesion that was suspicious and subsequently biopsied as Gleason 3+5. So now we identified this patient as in the high-risk group. In addition, the MRI had noted that there were some possible bone lesions, which was actually read as suspicious for bone metastasis. We followed that up with an Axumin PET scan, which is specific for prostate cancer, and that verified that these bone lesions were suspicious or highly suspicious, and talking to our radiologists. So ultimately, this patient was identified to have fairly definitive evidence of systemic disease, and they were treated with androgen deprivation therapy and also abiraterone for metastatic castrate-sensitive prostate cancer. There was some discussion of also doing radiation, but the radiation oncologist did not feel it would be helpful. This patient has been followed to date. PSA has been undetectable on continued androgen deprivation therapy. But I highlight here in the reports, the take-home point, this patient's CT scan was reported as normal. and they also had a bone scan, a traditional bone scan, which was reported as normal. So if this was a patient you just evaluated with CT and bone scan, we'd be treating him as localized disease. However, with an MRI and with an axiom and PET scan, they were an entirely different situation. So you want to keep in mind these patients that just don't seem to quite fit the appropriate scenario. And then now we'll jump into high-risk prostate cancer, looking at initial treatment and therapy for high-risk disease. So another question from one of the prior lectures, what level 1 evidence do we have for treatment of high-risk non-metastatic prostate cancer? So you can see this gentleman protesting, what do we want? Evidence-based change. When do we want it? Of course, after peer review. And so quite facetiously, I would note this paper that was published. There's kind of a joke version of the BMJ that comes out every year, but this paper had looked at the use of parachutes and had identified that there's been no randomized controlled trial level 1 evidence of the value of parachutes in preventing death when jumping from airplanes. So, it's a little bit flippant, but that kind of idea we have to keep in mind based on the fact that there have not been any large-scale randomized trials of large volumes of high-risk prostate cancer patients treated versus observation, but there is some data in that space which we'll now kind of transition to talking about. So I'm a big advocate for going to NCCN guidelines and AUA guidelines, and we'll talk about both of those specific populations. And so one thing that we keep in mind, especially in this scenario, is looking at life expectancy. And so one of the things that's quite notable, if you look at NCCN guidelines for high risk or very high risk prostate cancer, is we're not talking about a 10-year life expectancy that like we do talk about with screening, but it's really looking at if a patient has a greater than 5-year life expectancy, then considering active treatment with radiation or prostatectomy, and we'll talk about those in detail, and only considering observation for patients with a less than 5-year life expectancy. And even in that space, there's still some discussion or an option of doing androgen deprivation therapy or radiation in some patients. And so when we look at that scenario, it's important to distinguish that 5-year time point, which I kind of alluded to here. But the other thing that I would throw out there that people should be familiar with is you can calculate someone's life expectancy relatively straightforward method. You Google Social Security life tables, and if you look at when do men have a less than 5-year life expectancy, it's not actually until they get to the age of 87. And so I think what happens is the patients who happen to get to their 80s are healthy enough that a number of them will still live a number of years beyond that. The other thing I would highlight is that I did a little algebra. And there are guidelines, including an NCCN. If a patient is in the healthiest quartile for their age, then you can add an additional 50% to that life expectancy calculator. So I verified this with my 12-year-old this morning, but there's our algebra equation. And so if we take a prediction of about 3.3 years, but it's the healthiest quartile of those patients, it's not actually until you get to someone around 92 or 93 where we would estimate that their life expectancy is less than 5 years. So I think there's certainly something counterintuitive about that concept. But these are the numbers. This is actuarial data. You want to be aware of the fact that there may be some patients in their 70s or their 80s who may live 5, 10 years or even further. And so if we look at this specific treatment matrix of here are these patients with high-risk disease, should we give them radiation or should we treat them with prostatectomy, or why not just do nothing? It's important to note that there's not large-scale randomized controlled data about radiation, versus prostatectomy. It's worth noting where we do have, some data. And so Dr. Ristow from Connecticut had talked about the PROTECT trial, and that had included arms of active monitoring, radiation, prostatectomy. So this is exactly the type of population and the type of study that we need to answer this question. However, it's worth noting that at a median follow-up of 10 years, this study only had 1 to 2% prostate cancer mortality, and there were not a high amount of high-grade prostate cancer patients. And so it's really significantly underpowered to tell us anything about high risk. And if you look at this paper,
they specifically are not making any conclusions about, how to treat high-risk prostate cancer. The other main point I would highlight from this paper is at study entry, these patients were felt to have a greater than 10-year life expectancy. And if you look at the all-cause mortality at a follow-up of 10 years, it was quite low, which is what it should be. The number of patients who had died of any cause was about 10%. And so importantly, we're going to contrast that later when we talk about PIVOT, which is predominantly done in the VA healthcare system. With PIVOT, the 10 to 12-year overall mortality rate was 50%. And so you always have to keep that in mind when you talk about the PIVOT study and what you can generalize from that in the overall populations. And so I think specifically here we look and we say there were very few patients who had Gleason score 8 to 10. Only 10 to 14 of them. And the majority of patients in this PROTECT trial had low grade, Gleason 6 grade group 1 disease. And there's so few deaths that you really can't statistically or clinically comment on high-risk treatment using the PROTECT, randomized controlled data. So what can we do with observational data? I'll plug a paper that we looked at when I was in fellowship. So we had a large group of patients treated at WashU or at Cleveland Clinic, and we had their survival outcomes. And so the concept we came up with, because we had a comorbidity assessment, was let's take the healthiest patients who had no documented comorbidity at all, and let's compare them and see what their outcomes were. And so the result of this study was, if you used a traditional Cox proportional hazard statistical model, it would tell you that surgery had a prostate cancer mortality benefit over radiation. So that's, as surgeons, what we like to hear, and that may be the truth, but if you use a different fine and grade competing risk analysis, a different statistical test, there's no longer any difference. And so that tells you that if there's a difference, it potentially is subtle or maybe not even existent. The other thing that this study showed, and we'll show the cumulative incidence plots here, keeping in mind the y-axis is somewhat truncated to try to identify if there's a difference. But if you see in this study, the overall mortality curves, there was an overall mortality benefit associated with patients who had surgery compared to having radiation. However, you just cannot get away from the question of whether that is truly a surgical benefit or whether that's patient selection and there's some unmeasured comorbidity that we're not able to assess in this type of study. The other thing I would postulate is, if cancer treatment for high risk is actually better because of surgery, it's probably because the second line option with salvage or adjuvant radiation therapy is still with curative intent. And so if surgery is better, it's probably because of an increased use of radiation afterwards, in context to someone who gets primary radiation and then rarely goes on to get a salvage prostatectomy if there's recurrence. But I think this type of population-based data is helpful to at least think about this question. So now if we jump from NCCN to what AUA and ASTRO guidelines talk about. So there are a few guideline statements. So Combined Urology and Radiation Associations got together and they said that for high-risk prostate cancer, which is what this guideline statement is about, clinicians should recommend either prostatectomy or radiation plus androgen deprivation therapy for patients with high-risk prostate cancer. So we've talked about that, but we're going to talk a little bit about the data they allude to. And they're not recommending active surveillance in this population, which makes sense to all of us. And they said watchful waiting, so doing nothing, should really only be considered in asymptomatic men who have a limited life expectancy. So this is in alignment with the discussion in the NCCN guidelines. They also did not recommend some other, which are maybe more experimental at this point, treatments with cryotherapy or focal therapy or HIFU. And specifically, they also call out that they don't recommend primary androgen deprivation therapy as the only treatment unless the patient has a limited life expectancy in symptoms and you're just trying to palliate in that space. So I took one more deeper dive into that and said, from this guideline statement, what's the data that they are alluding to? And so what was noted for this recommendation in favor of active treatment was a couple of things. One was the SPCG4 trial, which was the Scandinavian randomized trial looking at the benefit that was seen with surgery compared to observation. And the other part that they looked at and commented about was that there was not an overall survival benefit in the PIVOT study. However, if you looked in the high-risk patient population group, it did appear that there were potentially less bone metastasis. And specifically, and I've got a slide on this coming up, if you look at high-risk men, the rate of prostate cancer mortality in that group was actually significantly lower, 9.1% versus 17.5% in observation. So you always have to be careful if you have a large randomized trial about over-interpreting the subgroup analysis, but that's what they're talking about in this situation. You know, and when they say, why not just watch, this is kind of the counter version of the same data and the same reasoning that we just talked about. And then we'll kind of slide by this one because the palliation and you know, ADT kind of makes sense. But if we look and we dive now into this specific data on what is the specific data to favor prostatectomy in these patients, you know, what was alluded to was the Scandinavian trial and also knowing that these patients are very high risk. And so we're going to jump slightly into the PIVOT trial, which Dr. Ristow had talked about. So this is observation versus radical prostatectomy, predominantly in the VA healthcare system. And so in this group, and I included Ben's slides there, along with some figures from the actual paper, we keep in mind in this population, only 21% of patients were high risk, only 48% were intermediate or high risk as far as Gleason score. And so the minority of patients were high risk in this study. But if you look at their forest plots, they did identify for patients with a PSA above 10 that there was a survival benefit with prostatectomy. They also commented on a potentially significant interaction between risk group and treatment. And as you can see, the intermediate and high risk hazard ratio, the box is favoring prostatectomy, but it's that the confidence intervals are relatively wide because of a lack of statistical power due to limited numbers. But if you go and dive into this paper, which I've kind of done for you here, they do talk about these relationships that we just had alluded to, and then specifically talked about with high-risk tumors, there was a reduction in mortality by about 6.7% percentage points. That's the box in the right, but it just was not statistically significant, either because of lack of true effect or because of sample size issues. And if we look at the prostate cancer death rate, which we alluded to, this is the visual formation of it, you see that for high-risk prostate cancer patients, so the one that's right here by my arrow, there is a 40% risk reduction, actually a 60%, hazard ratios down to 0.4, risk reduction in prostate cancer mortality, and that's right at about the 0.04, 0.05 level. And you say, from the AUA statement, where did that 9.1% versus 70.5% data come from with decreased prostate cancer mortality? This is the actual portion of the paper that talks about it specifically. And so what about the Scandinavian trial? What can we learn about it from respect to high-risk prostate cancer? The thing I would note with this study is it also is underpowered in high-risk patient populations. And the authors in the most recent form, which was published in 2018, I actually took a look again at this last night, and they don't really call out the high-risk population here. And when there's a letter to the editor afterwards kind of inquiring about risk group, subgroup analysis, they specifically say, they've repeatedly cautioned in this article and other articles that subgroup analysis are exploratory and have low statistical precision. So part of that came from a cutoff, benefit was largest in patients less than the age of 65 in this study. And so I think that group had kind of backed away some previous statements about whether age is sort of a subgroup cutoff, or whether high-risk patients should be that subgroup analysis is valid. If you do look back, and Ben had this data in his slide, if you look back at their 2014 analysis, they did not statistically see that there was a benefit in the high-risk population. It appeared to be that the driving factor was benefit of prostatectomy in the intermediate risk, patient population. But the authors had discussed about how this doesn't really fit with what is kind of thought clinically and with pivot, but they had noted that this was a very high-risk population as far as the risk of micrometastatic disease. In Scandinavia, they had not been screened with PSA, and so they commented that it may be because of that higher rate of micrometastasis that they're not seeing a benefit here. But it's worth noting that when they published an update, they entirely went away from trying to make any statement about high risk versus intermediate risk in this population. So, part of data is anecdotal too. So I put yourself in the shoes of the surgeon. So what are you going to do with this patient? So 63-year-old African-American patient, had never had a PSA before. And this was actually relatively early in my practice, about 2013. So he came in, PSA was 41.63. We rechecked it was 54.23. We staged him. He had no evidence of disease elsewhere. And I remember this one specifically, reached out to a few colleagues from training and elsewhere and said, hey, do you have an upper limit for where you don't do a prostatectomy? And the most common response is, well, in the appropriate patient, there's not exactly an upper limit. And so what we did for this patient is we went ahead and did a prostatectomy. He ended up, despite that high PSA, only having a Gleason 4+3 disease, and his pathology was T3N0. As we note there, did have a positive bladder neck margins, but all other margins were negative. He had 11 pelvic lymph nodes, which were negative. So the PSA after surgery was undetectable. We talked about the option of doing radiation therapy, but we kind of combined a discussion to say, well, let's just follow closely. And to date, he's had no evidence of PSA recurrence. That was 2013. Now we're to 2020. His PSA has continued to be undetectable. And so, not all high-risk prostate cancer surgeries go like this, and you want to have kind of lowered expectations in that patient population. But there are some cases like this where it appears this guy clearly benefited from having surgery and had relatively low morbidity related to that. And so I'll just kind of leave this here. I'll share my slides afterwards with the group and the website. But what I do, when I have these patients where I feel like I'm really looking at things in depth, and have a good plan documented, then I'll make a smart phrase so I have that available to me down the road. And specifically, I pulled this one back up, as I'm doing this talk. If you look for data for doing a prostatectomy and PSA above 50, you don't find a lot of it. But there were a couple of examples kind of in the middle of that smart phrase there, where there was some anecdotal experience with patients with PSA above 100 who had a prostatectomy. And then, the outcomes are listed there, that the cancer-specific survival, even in that patient population with a moderate follow-up of about 6 years, was about 88%. So only about 12% of patients had died of prostate cancer in that population. And so you want to keep in mind as you're counseling patients sort of in these unusual type scenarios, what's out there, and also discussing, what are realistic expectations. So real quickly, because Dr. Ristow had done a great job with this, as far as with radiation therapy, if patients opt to go that route, it is combined with androgen deprivation therapy. This is a tremendous summary of the data, so I'm not going to reiterate much here. But basically is that high-risk patients should also have, 2 to 3 years of androgen deprivation therapy. So in looking at some of these guideline statements, it's actually an interesting thing to say, well, what's the benefit of doing, this treatment versus doing nothing? And so one of the points they'll make is that these studies all showed a survival benefit of additional androgen deprivation therapy beyond just radiation therapy. So you would then postulate that patients who had no treatment would do even worse than those patients who had no radiation or who had radiation and short course of androgen deprivation therapy. So it's extrapolated level 1 evidence, but there's at least some evidence, to kind of justify treating patients who have a greater than 5-year, life expectancy. I'm going to just leave this one here. because there's not a lot of specific data available for surgeons in patients who have regional risk group disease. So lymph node enlargement. So if you look at what the NCCN guidelines state, they really talk about using radiation in those patients, or consideration of abiraterone for patients. You know, I think in clinical practice, there are many of us that if there is a small-ish 1 centimeter, 1.5 centimeter indeterminate node, that we will definitely consider surgery, because some of those nodes are negative, and we don't want to necessarily exclude patients from surgery in that context. There also is data that I won't really get into, but there's a SWOG study Brian Chapin is leading, looking at is there a benefit of prostatectomy in patients with low volume metastatic disease, be it either lymph node involvement or low volume of bony disease. But this is really kind of a patient population that these patients, if they're going to be treated with a prostatectomy, it's probably best to be treated, you know, in the context of a clinical trial. And so this is in patients with metastatic disease. So outside the topic that we're talking about, but that's where that prior slide data comes from, is that patients who had low volume metastatic disease appeared to benefit from abiraterone and including radiation in some of those patients. So that's really where that prior data comes from, is this study that showed a potential benefit called STAMPEDE in patients with low volume metastatic disease. So we're going to transition here about the next 5 minutes or so, maybe a little bit more, into what about now you have chosen surgery, you know, or radiation, and should a patient then receive additional adjuvant therapy? This is specifically in the surgical population. And so the important concept, you know, to keep in mind is you're looking at different time periods. So neoadjuvant would be something before surgery. Adjuvant is in the period after surgery. Specifically for adjuvant radiation therapy after prostatectomy, the data is really looking at within 17, 18 weeks after surgery, versus salvage radiation therapy, which is done, you know, down the road. And so in the context of that study, here's an annotated slide from the NCCN guidelines. So if you do a prostatectomy and there are adverse features, so we're talking about PT3N0 disease or maybe T2 disease with positive margins, that there's consideration of adjuvant radiation therapy versus observation in that group. We'll also talk about if lymph nodes are positive, there's consideration of androgen deprivation therapy, radiation therapy versus observation. What's important to note is there's not currently a neoadjuvant therapy for these high-risk prostate cancer patients. The study has been done in general for prostate cancer patients, giving androgen deprivation therapy before surgery. That did not have a survival benefit. It just decreased the rate of positive surgical margins. That's a very classic in-service test question. So we don't do androgen deprivation therapy in that population. The other trial that's currently kind of pending, has been reported at meetings, but I looked again last night and didn't see that it has been published yet, is looking at docetaxel before prostatectomy in high-risk patients. There appears to be some favorable data with that population, but it just has not been fully evaluated and published yet. So let's talk specifically about this adverse patient group. So I have our residents, if you're going to know one SWOG study and one set of numbers, it's SWOG 8794. So these were patients with T3N0 disease, and they were randomized to either getting adjuvant radiation therapy within 16 weeks of surgery versus observation. And keeping in mind, early salvage radiation therapy was not evaluated. So they weren't comparing radiation you know, right away compared to radiation 6 months later if the PSA is undetectable. But this was really doing radiation versus really not doing it at all, or very late down the road. And so this T3N0 population, initial paper actually did not show a survival benefit, but this follow-up evaluation from Ian Thompson at 12.7 years showed that there was a metastasis-free survival benefit of adjuvant radiation therapy for T3N0 disease. And there was also in patients who had a detectable versus undetectable PSA. So this is your justification. If you have T3N0 disease, PSA is still undetectable, you still have the option of offering those patients radiation therapy. And most importantly, that showed that there was a survival benefit in adjuvant radiation therapy versus just watching things, which is shown there. And then the other question is whether to combine that radiation therapy with androgen deprivation therapy. So my practice had been to not give androgen deprivation therapy. We just give radiation, we see if the PSA comes down. However, this all changed with Shipley publication in 2017, at least in my practice. They showed that if you combine 2 years of radiation, of androgen deprivation therapy with the radiation, that there was a significant survival advantage, and the prostate cancer mortality decreased from 13.4% down to 5.8%. So for me, this randomized controlled trial, New England Journal 2017, kind of abruptly changed my practice in that patient population. If I give adjuvant radiation therapy or I give early salvage radiation therapy, I'm promoting androgen deprivation therapy in most patients, but keeping in mind that if they don't tolerate it, it potentially can be stopped. So we're going to switch to a slightly different patient population here. So this is patients that have node positive disease with your prostatectomy. So we always refer to it as the messing data. So node positive patients who were randomized to either get androgen deprivation therapy versus observation starting soon after surgery. The patient follow-up was kind of at a medium level as far as 7.1 years. And keeping in mind, most of these patients had kind of 1 or 2 positive nodes. And so what they found was there was a pretty significant difference in clinical progression, which is shown here, which is really defined by CT scan, bone scan, radiographic imaging. And importantly, though, is that there was an overall survival benefit and a prostate cancer survival benefit. And these curves look almost identical. So what that tells us is the driving factor in this patient population, probably younger folks that received surgery, was their prostate cancer mortality. You're just simply not seeing a lot of other cause mortality. So this is the justification for node positive patients to start androgen deprivation therapy in this situation lifelong. And that's really what I at least discuss and talk to patients and show them this messing data, that with androgen deprivation therapy, in a cohort of about 50 patients, only 3 of them on androgen deprivation therapy died of prostate cancer compared to 16 in the observation group. So at least warrants discussion. However, transitioning, what's really being done in practice, population-based data in node-positive prostatectomy patients. So you see from that box there, over half of patients are treated with observation alone. About a quarter receive androgen deprivation alone. In a selected population, about 20% receive androgen deprivation therapy and radiation. And I think at least those latter, the last portion there, the multimodal treatment approach warrants consideration. This is retrospective data that these patients, most of them had 1 positive node. So what do you do with low volume patients? They found that, it's hard to control, it's not randomized, but patients who received radiation and androgen deprivation therapy for node positive prostate cancer had a survival advantage compared to the other groups. And you can see the survival curves there are different. We still have to keep in mind there potentially is an issue of unadjusted, confounding in this population, but at least there's population-based data to recommend being aggressive in patients in that situation. So finish up the last few minutes here. I'll talk about biochemical recurrence. I think it's important for everybody to know the definition. And so specifically in this slide here, our typical definition, AUA definition of biochemical recurrence, is a PSA above 0.2. The concept being a very low PSA below that might be benign prostate cells. If you look at the NCCN definition, they actually talk about detectable PSA, which is then subsequently detectable and increases on repeat checks. So NCCN definition of biochemical recurrence after prostatectomy may actually be talking about patients who are not at 0.2. For radiation, it's really the lowest PSA plus 2.0 above that, which is called the Phoenix criteria. And so, I think we'll leave this mostly as available for a reference, but we'll kind of summarize in patients who have, biochemical recurrence after prostatectomy. You want to consider repeat imaging in those patients. And then we've already talked about the potential benefit of radiation plus 2 years of androgen deprivation therapy. If they have distant disease in that metastatic workup, then obviously they're treated with systemic therapy. And so if you look at this study that looked at cancer control, which I think was relevant, if you look at overall, this is probably a low-risk population predominantly, but the failure to control cancer, they defined it as a detectable PSA at all, was about 12% at 2 years in a pretty low-risk, population. But what you saw is that patients that had a detectable PSA, if you follow them over time, that they're about as likely to die of prostate cancer as they are to die of other causes. And so we really have to, as urologists, be able to flip from the mindset of, well, prostate cancer may not really be a significant disease for low-grade, patients. We talk about active surveillance or doing nothing. You have to be able to flip into this different mindset that a patient with biochemical recurrence is potentially at risk of prostate cancer mortality, and it may be equal to their other risks of mortality. And so flipping over to patient had radiation and they have recurrence, those are patients that you're considering. You're looking to see if they have distant disease. If not, there may be some patients who receive salvage radical prostatectomy that are very highly selected. The reason for that being the risk of rectal injury is higher after radiation with salvage prostatectomy. And also, I don't go into the data, but there's a relatively high PSA recurrence rate after salvage prostatectomy or salvage cryotherapy. And so you want to have realistic expectations that they may have micrometastatic disease elsewhere in the body, which you're not knowing about at that context. And then talk just really briefly, we want to keep in mind that if patients don't have documented metastatic disease, but their PSA is rising despite androgen deprivation therapy, so they're castrate-resistant prostate cancer, there are a number of medications, apalutamide, darolutamide, enzalutamide, that are now approved in that space if their PSA is rising quickly. So those are patients we always used to be watching, but now there's medication in patients who are non-metastatic but castrate resistance. So let's review what we covered. Are we in line with what the AUA and ASTRO guidelines talk about? So notably, these guidelines came out and they were updated in 2018, 2019. And so first guideline statement, talk about the potential need for multimodal therapy. We discussed that. Guideline statement 2 is patients who have higher risk disease, you should consider the option of doing additional radiation therapy. We discussed that. I think in my practice, most of the folks I've worked with, we will discuss the option of adjuvant radiation therapy. But my general practice is if the PSA is undetectable, the pathology is relatively favorable, say T3N0, but negative margins, negative nodes, we may be considering watching those patients, but having a very early trigger for doing salvage radiation therapy. But that's one spot there's specific practice variability. Keep in mind, if you radiate every T3N0 patient, you're going to overtreat some patients, you're going to run into side effect issues more commonly. If you don't treat anyone, then you're going to potentially risk your chance for cure in some patients. So other statements talk about the chance of PSA recurrence and that's a bad thing. Yep, we talked about that, that we should know the biochemical recurrence definitions. We're aware of that. And then they talked about staging patients with PSA recurrence should be considered, but I would change that to done and advocate it. You want to radiographically work up patients with recurrence, and then offering salvage radiation therapy in patients. And so we've covered most of that. That there's a general concept that we're better off radiating patients if their PSA is 0.2 compared to 2.2, and we want to consider earlier radiation as salvage there. And then this guideline statement was updated with the androgen deprivation Shipley data that we talked about. And then this last statement really just balancing the benefits from a cancer control standpoint versus the potential risk. So I'm going to do 1 minute on biochemical recurrence. You could have a whole hour on this, but I'm just going to give you what my perception is of imaging. And so specifically this patient was somebody who had a prostatectomy locally, and then he had rising PSA. All the details are there, but basically got salvage radiation therapy locally 2 years from surgery, but his PSA continued to rise up to 1.17. So he came for evaluation. We did imaging. He ended up with an Axumin PET scan. So that's an FDA-approved PET scan for biochemical recurrence. We also had a research protocol that was open for using a PSMA, non-FDA-approved research but probably a little better PET scan. Most people feel that. And so he had disease in one lymph node in the pelvis. We show the pictures there, and had kind of this indeterminate uptake in his lungs that our radiologist felt was most likely negative. So we said, well, let's go ahead and do a salvage pelvic lymph node dissection after prior prostatectomy and prior radiation. So did the surgery. We could actually visibly see the node and then see another node next to it. We really tried to clean out the whole pelvis and ended up with 36 lymph nodes, 2 of which were positive, identifying that lymph node that we saw on scan. And literally in my mind is that this is the way we're going to change high-risk prostate cancer treatment because we're going to save all these patients. Pre-op PSA for 1.17. Unfortunately, post-op PSA barely budged. And so patient was actually okay with this because we had talked about the specific chance we may not do anything that's beneficial in the space, but we can get the lymph nodes out with limited morbidity. And then subsequently, as PSA continued to rise, he ended up getting a choline PET scan, showed increased uptake in the lungs, and subsequently was treated with androgen deprivation therapy and docetaxel. So in the past, we very rarely discussed prostate cancer to the lungs, but this is an example, and there's other ones out there of prostate cancer clearly going to the lungs. And so the take-home message that I would say, I'll leave these slides here for reference, but I would note that there's continued issues with small lymph nodes. This is Dr. Pollard, one of our radiation issue because we don't know if they're positive or if they're benign. There's a number of different agents available, and for what you need to know right now is that an ADJUVANT PET scan is FDA approved and typically covered by insurance for patients who have biochemical recurrence. So that's typically defined as a PSA above 0.2, after prostatectomy. So this is something that's in our typical kind of armamentarium now as far as ways to evaluate these patients. But what we keep in mind, even though this is FDA approved, is the issue that for low PSAs, it's not very accurate at finding, disease. And so if we contrast that to PSMA, which is widely used in Europe, now available in the US just on research protocols, we're one of 10 or 12 different places that are looking at PSMA testing for biochemical recurrence and also high-risk prostate cancer patients. And PSMA is probably a better test to identify and look at recurrence, but it's just not FDA approved currently. This is the one slide I think to be aware of. If the PSA is less than 1, as choline PET or a ADJUVANT, which is the fluciclovine PET, has a very low chance of showing something, but the PSMA might. And so there are some specific patients where we're kind of waiting until the PSA is around, a little bit higher to see if we find something or not. But this is really patient specific. And this is a graph that Janet had put together. If the PSA is low, you're probably not going to find anything with a choline or an ADJUVANT, PET scan. And so her take-home points are there, but this is clearly the direction we're going to be moving, and an area of very active study. Ideally within hopefully the next 2 to 3 years, PSMA may be approved, and I think that's going to be the one that's potentially more of a game changer. One slide just for reference is high-risk prostate cancer patients who are metastatic or regionally advanced. Now NCCN does provide guidance in doing genetic testing in those patients, potentially with somatic testing of the specimen. Also, specific driving factor for that is that patients that are BRCA positive, there now are a group of medications that are used in potentially metastatic disease in that patient population. So actually, genetics may be changing how we change and manage some of these patients. So. All right, and I'm sure Justin has some questions for us, and I know we're running up on our time, but I'm happy to answer a few more questions, maybe run a little bit over since I'm sure there's looks like a little bit of an active chat.
All right, Dr. Nepple, thank you very much for the great talk. It was a lot of excellent information. There are a few questions. I think one I'd like to start with, I think ties nicely the middle of your talk to the end of your talk, and it was regarding your case from 2013 with the 63-year-old gentleman. The question is, I guess if you could fast forward to today and FDA recommendations aside, would PSMA have a role in assessing for need for adjuvant radiation, or would you still wait until biochemical recurrence prior to considering adjuvant radiation in that patient?
Sure. I think I'll answer that in 2 contexts. One is what we're able to do, right now. And so what we keep in mind right now is I can get an ex-human PET scan paid for if the PSA is 0.2. And so if the PSA was 0.1 and the patient had high-risk pathology, then I'm really contemplating, do I want to wait until the PSA is 0.2, knowing that it's probably only going to show something 5, 10, 15% of the times. And so there might be some patients where if they don't want to jump right towards adjuvant or early salvage radiation therapy, maybe they're still having some recovery of incontinence or there's other reasons, then I will talk to them about, well, okay, once we get to 0.2, then we're going to get an ex-human PET scan and we're going to have that drive what our treatment is. There are some scans that will show, I just have a patient managing this week, his ex-human scan showed a small bone lesion, about 8 millimeters. And so I had radiology try to biopsy it. They said it's too small. And they said get an MRI if it's enhancing, it's suspicious. And so that patient, we're going to have a tumor board discussion about, but most likely we're going to be looking at directed radiation to that bone lesion in the pelvis, plus or minus prostate bed pelvic radiation, potentially combined with androgen deprivation therapy. So in the current context, almost nobody's going to be willing to pay for an ex-human out of pocket. We had a heyday and filled our PSMA protocol up very, very quickly when we had that for the biochemical recurrence patients. I think it was helpful in guiding management that was appropriate. You would see occasionally a patient who had no disease in the pelvis, but had a couple of spine lesions. And so rather than treat with pelvic radiation, they're potentially getting systemic therapy plus bone-directed radiation to the spine. And so PSMA, I think, is going to be great, but it's currently not available. And I think we're working on a protocol for out-of-pocket testing, which is probably going to be, in the neighborhood of $2,500 or something like that. And so again, for the very low PSA, if my PSA was 0.2, I don't know that I would necessarily pay out of pocket to get a PSMA. But once it's available and covered, then it's going to be, I think, part of all of our sort of information that we look at. I think the other real quick point is we also have to keep in mind with these tracers in advanced imaging that they're not always accurate. I've had a number of patients who had positive bone lesions, called on MRI of the prostate. I got a bone scan that was negative. We said, we probably think this is not disease. It's probably a false positive. And then if you do their prostatectomy, their PSA is undetectable. You say, great, that the radiology wasn't right. But we really have to consider on a patient-by-patient basis, if you were to get, for example, theoretically a PSMA before surgery, and there was a tiny lymph node high up in the abdomen, another small lymph node in the pelvis, are we going to exclude those patients from the attempt at local control because of possible radiographic disease elsewhere? So I think that's something that's clearly going to be an active area of research and discussion.
Great, thank you very much. One more question here. Can you give ADT for borderline Axeman PET scans, so whether it's borderline for positive or negative, assess the response after ADT, and then maybe make a better determination on whether or not there was a true MET there?
Yeah, and so one of the benefits I was going to mention early on, but I worked with Dr. Williams, who had been here for 25 years, and so he would almost never refer his patients to locally for follow-up. So his clinics would be full of these patients who had 5, 10, 15, 20 years of follow-up. So you see all these different patterns. And back then we would have was Prostate, which was also PSMA, but intramembrane, intracytoplasmic version of the binding. So it was a very limited study. But there were some patients where you would think you see something, and then you do androgen deprivation therapy and you see if it responds. So there are some select patients where we do that. The most recent one I would that comes to mind was, you're really deciding based on that PSMA or, more commonly the ex-human or other imaging, if you're treating a patient as systemic or localized disease. And I still fall back on my clinical judgment oftentimes in those patients. If they're, Gleason 7 disease and their PSA is 9, and it's thought that they might have a bone lesion, you can say that's probably relatively unlikely. And so there's some patients like that we do treat, with surgery or radiation with curative intent, specifically on the androgen deprivation plus radiation option. Then you can see if those lesions respond. And if they don't change, then it's probably not disease. but you're never 100% accurate in that space. But the combination of repeat radiographic imaging plus what their PSA does, I think does potentially point us in the right direction.
Good deal. And then can you comment briefly, what are your thoughts on deferring adjuvant radiation to allow for better outcomes, specifically regarding continence or erectile dysfunction, instead of opting for early salvage XRT? And I've heard you talk about this in clinic, but maybe you could give a little comment on your personal practice.
Yeah. The request to comment briefly, I can never do that, but I'll give you a few thoughts that jump into my head. So, I think that's definitely part of the consideration, is that people are still healing, and for a long time, it was discussion of, if you do radiate, you're going to freeze them into where they are. I would point people towards that Swag-Thompson, SWOG 8794 study. There are also studies looking at quality of life outcomes after adjuvant versus observation. The surprising thing from that was that it didn't appear that the continence was heavily impacted, and there was a higher rate of bladder neck contractures. But I think in this situation, we can all feel like we're being oncologically safe in potentially monitoring the PSA, closely and allowing some time for recovery. And so I think you have that kind of potential win-win of giving the patient some time to recover, and then seeing what their PSA does. But what that means for my specific practice is there's very few patients that I give adjuvant radiation therapy unless they're clearly very high, pathologic risk, and their PSA is higher than we want, after surgery. But I think whoever asked that question is right on top of it, as far as you want to take all this into account. And I think specifically the young patient who is starting to get back partial erections and starting to get back to their life, and they have an undetectable PSA. It's a little bit hard. You would almost have to arm wrestle that patient into getting radiation and committing to that 6-7 week treatment plan when they're just starting to feel normal, more normal, new normal, and they're just starting to get their erections back. So I think you want to at least inform patients of what the data is, but say, hey, we have this alternative option where we may give you some additional time to be a normal person before we put you back into a daily, being a patient on a daily basis.
Sure thing. Well, I know we're a few minutes over. Do you want to keep going? We can post the rest of these questions on the website if you'd like.
Yeah, let's do like maybe one or two.
Sure. All right. So then there's one more. It's a little bit more relevant for today's times. But a candidate for a radical prostatectomy with a PSA greater than 50, if this patient, in the future were to be delayed for surgery greater than 6 months because of something like COVID, would you start ADT while you're waiting for this patient to have surgery?
Yeah, that's a good point. And my hobby for a little while was listening to podcasts on telehealth and also on urologic management of COVID. And I think everyone felt that those are the types of patients that most commonly were still proceeding with surgery. In the state of Iowa, we termed that as essential surgery, and we're able to do that. But multiple different folks on podcasts talked about, if you could not do surgery, then that certainly is a patient that could be temporized with androgen deprivation therapy. And so I've heard that from multiple different folks, and I know that was my kind of impression too. I know Sam Chang specifically was on one of the AUA podcasts and talked about that. So I think that would certainly be a relevant thing. And if I was that patient, I would at least get some peace of mind, with that.
Good deal. You want one more?
Sure.
Okay.
Yeah, it looks like we still have like 40 people on, so people can feel free to jump off if they want, but I got nothing but time to look at your mustache.
Good deal. Yeah, thank you for the mustache shout out. So this is a case-based question, but this is a case regarding a 73-year-old healthy gentleman with a PIRADS 5 lesion on MRI. Looks like prostate biopsy has 8 of 13 cores are positive for just grade group 1 with no symptoms, but the PSA continues to increase from 13 to 18 within 3 months. And so is this a patient you would consider prostatectomy on, or would you favor ADT and EBIC?
Yeah, so that's a patient I would be talking about active treatment, you know, the discussion being either surgery versus radiation. The way I phrase it that I think is effective is if patients potentially don't want to do something, I'll talk to them about who the ideal candidate for active surveillance is. And so the ideal candidate is a patient who has, you know, Gleason 6, but it's 2 or fewer cores. They have less than 50%, you know, core involvement, and their PSA is less than 10, you know. So once you're into that PSA, you know, 13 and rising, it might just be related to inflammation, or it might be related to prostate enlargement. In those patients, you know, you have a PSA size or a prostate size from your MRI. It's good to use PSA density also. But they're the folks I would talk to about how I just feel nervous that we might miss the window for cure. I try not to use that cure word, but I think there are patients in my practice who go both ways. There's folks who really don't want to do treatment, and so we're watching them closely. I'm much more comforted by the fact that I have a good MRI and I have a good fusion biopsy compared to if I don't. And so in that patient, I wouldn't absolutely twist their arm that they're going to shorten their life because of that. But you know, I think that those are the ones that you really want to have an active discussion and sort of to some extent, you know, commit. There's also in that specific patient population where people are on the fence. That is where I will consider using adjuvant pathologic, you know, classifier tests such as Decipher, Oncocyte, Polaris is another one. But I'll go into it and tell the patient, hey, let's do this test, but let's only do it if it's going to change what our management is. And so we'll kind of draw out a plan and say, okay, if this shows that you're in the high risk category or higher intermediate risk category, then is it going to prompt us to do active treatment, you know, versus watch if it's in the lower risk category. And so I will only do those if it's really going to change what we do, because otherwise there's better ways to spend, you know, $2,000 or $2,200 in that neighborhood. Okay, good. Yeah, let's do one or two more. People are still hanging in there. Impressive.
All right. The last question we have on here actually is, so for patients, I think you may have talked about this in your talk a little bit, but maybe you could clarify. For patients who have prostatectomy and then have biochemical recurrence and undergo radiation, what PSA cutoffs are you using to follow these patients afterwards, given that they've had both?
Sure. And so it's an important point. One I thought about making, but I didn't, which is a little off topic, is that I don't trust anyone, you know, who's not a urologist to follow a patient's PSA. There's some patients that I'm fine if they follow up with their local urologist, but I've just seen anecdotally too many examples of patients post-prostatectomy who their PSA is 0.2, 0.4, 0.6, you know, and it's just clicked off as a normal result from their primary care provider just because it's not on their radar. But the point you get at there is that if you have radiation for biochemical recurrence, so let's say the PSA is 0.3. So back when I was doing, you know, and seeing 10 years worth of patients in Dr. Williams' clinic who had radiation only, you really want to see their PSA go to completely undetectable with radiation alone. And that would be a marker that they had pelvic disease and that you potentially are going to cure them. But I would say for certain, even if you just did androgen deprivation therapy, their PSA should go to completely undetectable. And for sure, if you're combining salvage radiation and ADT, their PSA should be undetectable. The people that drop down, you know, from 0.3 down to 0.1, you know, I'll tell them, you know, hey, we talked about 2 years of androgen deprivation therapy, but I can kind of predict based on how things are going that your PSA may plateau, but then may start to rise. And so in those patients, if their PSA, you know, plateaus and then is rising, those are folks you're considering keeping on androgen deprivation therapy for a longer period of time. And then you're looking to see if they're developing castrate-resistant prostate cancer. And it may be, you know, the typical CRPC definition is a PSA above 2.0, you know, testosterone less than 50. So you verify the testosterone less than 50, but if their PSA goes 0.2, 0.4, 0.5, they have castrate-resistant prostate cancer. You're imaging them to determine if they're metastatic or if they're not. So some of those patients, you'll find that they actually have metastatic cancer that shows itself at that point, which then we're happy to look at systemic options. You're also in that population. If they're not metastatic, it goes back to that one slide. I just always encourage people, think about NCCN guidelines, think about which slide you're on with that patient. You may then identify that non-metastatic castrate-resistant prostate cancer patient, where if their PSA doubling time is less than 10 months, then they have the options of apalutamide or enzalutamide, the other medications that were in that box. And so you want to keep in mind, after salvage radiation, you're not using the Phoenix definition of the lowest it goes +2. We're really expecting that they go to undetectable, and we're following that population. Once things settle out, it might be every 6 months, but initially I'm usually keeping an eye on them every 3 months in between their 6-month androgen deprivation if they continue to be on ADT. Okay. All right, we have all the questions covered then, Dr. Drobish?
I think that covers all the questions. Dr. Nepple, once again, thank you very much for an excellent talk. It was very informative, and I appreciate the time very much.
Oh, you bet. Thank you for excellent moderator work, and I will share the slides in the near future. And if people have questions, my email was on the first slide. Can feel free to reach out to me also. All right, thanks everybody.